Thank you, Mrs. Chairman. Good morning. I go directly to the point, and the point is what hormones are doing and how we can use them today. And today is, I point today, because we have a long period of discussions over the last 15 years, what hormones can do for the female, because I have to admit, from the very moment, for the male, there are not existing data. All the data we have, it's one paper of 1970, and that's it. So the poor male has nothing to do with hormones. Of course, he has a lot, but at least on the therapeutic level. So we have to concentrate on the female. So actually, the current acceptance, what the hormone replacement therapy does, is that it is indicated in menopausal women to overcome the short-term and long-term consequences of estrogen deficiency. This is very clear, but behind this clarity, there are a lot of discussions. So the possibility we have to administrate the estrogen plus minus replacement treatment is an oral pill, the vaginal cream, transdermal and subdermal implant for a long-term treatment. The time point could be shortly before, during and after menopause, according to the clinical signs. And the accepted duration nowadays, in order to not to harm, it's the title of my lecture, is 3 to 5 years, starting with the beginning of menopause. This is a summary, and I'm going now to analyze what is behind the summary and what has to do all this information with the skin. Well, the possibilities we have is the combination of estrogens and progesterone in case that the woman has an uterus, and this is very clear because if you give only estrogens, we had high proliferation of the epithelium of the uterus, and this, in case that there is a predisposition, can lead to uterine cancer. The estrogens only, if the uterus is missing, and progestin only in very rare cases when we have hot flashes during the period of development of menopause. As a dermatologist, of course, if you think about giving hormone, you know two things. First, it is a matter of, not only a matter of looking, it's not a topical treatment. Even if you use them topically, it's a systemic treatment. We have about 20% of the compound being delivered systemically, even if you use it topically. So it's a systemic treatment, actually, what you do. And the second thing is that we know that you never give hormones as a primary treatment for the skin. So you have to have systemic points that we have discussed before, and you have, of course, then an added, let's say, advantage treating the skin. Until 2002, 2003, as you very well know, there was no discussion, at least in the northern, western part of Europe, every woman would get HRT. And it was advised by the gynecologist. Then we had two hits, one after the other, two major studies, which have shown two problems with that. I mean, tumor and thrombosis. And this was a black-white story. From the white you give, we went to the black you're not allowed to have. We can discuss very long about this. We can discuss very long, especially if you have read exactly these papers, and you're going to see what ages have been used, which women in what ages has been introduced in the clinical studies to find out if this works, and if it was proper, and what kind of estrogen. There are a lot of discussions. I don't bring any new things if I analyze them. But the point at the end of the day was the decision that no treatment will be done. Of course, there are always some very few exceptions. Taking the right of the woman to decide by itself. And I think this is a major issue we have to always to think about. You tell a woman, you are now at the menopause, there is no medical interest. And I say this from a German point of view because working in former East Germany, there was a state decision that every woman has to take contraceptives. So every woman received contraceptives in the productive time of life. As far as she went to menopause, the contraceptives were stopped. And you can imagine she has a double menopause. And you see the women in 5 years after menopause becoming real old. And this is an issue, I think, that has to be discussed and is discussed very, very carefully by the gynecologist in your decision, yes or no. In addition, we had an unlucky situation in Europe. The very prominent gynecological endocrinology went down to the privilege of gynecological oncology. If you look in Germany to try to see if there is any ordinarius, so director of a gynecological department being gynecological endocrinologist, you don't find any. In the times of the 70s, where all this discussion started, you had from the 36 ordinariats, you had at least the half with a gynecological endocrinology. So even this change has reduced knowledge. Now, the major side effects on which we base, or at least from 2003, is based the discussion not to give HRT to the women are endometrial cancer, breast cancer, and venous thromboembolic disease. In addition, we have gallbladder disease because of abnormal lipid metabolism in the lipids of the bladder. It's not systemic, it's a topical event. And we have something unexpected, actually. We have increased levels of dementia. Actually, the idea was to give HRT to reduce dementia, and you had increased dates, especially increased Alzheimer's. Now, going to the events that have been proven that occur with menopause, with the time after menopause. It's clear we have auditory degeneration, cancer, heart disease, and I say cancer, this means you have cancer even if you don't give HRT. Heart disease, muscular degeneration, neurodegeneration, you have Alzheimer if you don't give HRT. Optical degeneration, osteoporosis, which is a major issue. Skin aging, very well proven, and urinary incontinence. If you now isolate estrogens and the skin and try to see what estrogens make in the skin, there is a very powerful group of substances. It increases the proliferation of the keratinocytes. So it, as we discussed on the first day, it reduces the intrinsic aging, because intrinsic aging, as I told you, has to do with epithelium. So by increasing the proliferation of keratinocytes, you have, of course, a reduction of the progression of intrinsic aging. Of course, if you're on the other side of the boat, you're going to say, but it also increases the possibility of cancer, but because if you increase proliferation of alterated keratinocytes, maybe you increase epithelial cancer. The answer is very clear. Yes, of course, this is also possible, but epithelial cell cancer is something you can see and treat. So it's not so critical to the health like, let's say, the entire diseases that accumulate by aging of the skin, and also, don't forget, a major disease, the psychological factor. Then you have also an improvement of the function of the fibroblasts, especially the, not the proliferative, mostly the productive activity. This means you have also some kind of structural changes that reduce also the combined intrinsic extrinsic aging. And you have less inflammation, and you have heard also 2 days ago that inflammation is chronic in aging, and inflammation also induces cancer, because if we look at the epithelial cancer, you're going to see all epithelial cancers have perilesional inflammation. So this means it's a counterplay. You cannot say this is black and white. You can say there are factors improving the quality of the skin and preventing diseases, and vice versa. There is proof that if you give systemic estradiol, you have a parallel improvement of the bone density and the skin quality. And if you remember, again, the first day I have shown you the other curve, the hydroxyapatite and collagen going parallelly decreasing with age. Now you see another parallelity. If you give estradiol, only estrogen here, you have improvement of the skin thickness and parallelly quality of bone density. So there is clear proof that they go parallelly, these two organs, and you can improve skin, and parallelly you can improve the bone density. Now, again, if you go to look globally, what is going on at the phenotypic level? You have, if you give 2 to 5 years estradiol, immediately after menopause, you have increase of the hydration and sebum secretion. Sebum secretion is very important because we have a peculiar situation. While with menopause all functions of the organs go down, we have a vice versa activity of the sebaceous gland. The sebaceous gland overtakes the production of hormones, at least locally, but not only. So this means as far as sebaceous gland functions, you have a better quality of the skin. You don't have immediate aging. And if you have followed women for a long period of time, you're going to see that the woman does not age immediately with menopause. Of course, it happens if you have this double event, as I told you, with the contraception. But under normal conditions, women do not age immediately, skin aging, immediately after menopause. They age 10 years later, and they age rapidly 10 years later. And this follows parallelly the function of the sebaceous gland. We have a so-called sebaceous hypertrophy of the age, senile, I don't like the word, but this is what we use, senile sebaceous gland hypertrophy. The sebaceous gland grows up. And if you look here, you're going to see little papules. These are normal sebaceous glands. Because its cell, its sebaceous cell, loses in activity, the sebaceous gland hyperproliferates to compensate, and you have the same sebum secretion as you have it before menopause, but not only sebum, you have also hormones. For example, you have almost 100% of 5-alpha DHT for the body, from the skin. And this keeps about 10 years. And if you don't have a stimulator of the sebaceous glands go down after 10 years, and then you see this strong and quick and rapid aging. So this is also the reason why we have normal epidermal barrier lipids, the sweat production, the nail construction that has to do with keratinocyte function, and of course the skin texture, hair growth, which continues until it goes down with about 60, skin distensibility and hyperesthesis, and skin thickness. So all the parameters we use to count, to evaluate skin quality are improved by HRT, and we have a delay of aging of about 10 years. So if you have HRT for 2 to 5 years with menopause, you delay aging 10 years. Again, I don't say with this you have to give HRT for the skin. It's a secondary indication, but these are the facts. So we have to confront us with pro and contras. So what are the benefits of menopause hormones when used to prevent chronic conditions? What are the harms? On do benefits and harms differ by subgroups? Now, this last question arises very differentially during this period, black period 2003 and further, because again, there was a lot of big discussion. Is every woman in a danger to develop cancer if she takes HRT? Is every woman in danger to develop thrombosis? Or are subgroups that are strongly in danger and overcalculate the average risk? So do we have any possibility to differentiate and say these women cannot take because they have a huge risk, but the others are not in a risk? And this work has not been done yet. So let's see estrogens only. Estrogens only, again, if the woman has no uterus, it's the disease that of first choice. Here we have some interesting data, and these are data accumulating by the Agency of Health Research and Quality of the US, 2012. So there was a mid-evaluation of that. And you see, you have, unexpectedly, a different picture. You don't have increased breast cancer, but you have decreased breast cancer probability. And the mortality, even stronger decreased. You don't have, of course, bone fractures. This is clear. This is the most clear indication. You have still a risk of deep vein thrombosis. You have still the risk of local metabolism of lipids in the gallbladder. And you have still increase of urinary incontinence. So clear data which come from meta-analysis of the studies over the years. Now, if we go to the combination of estrogen and progestin, which is actually the treatment of first choice for women with the uterus, then you see what we had from the 1 million women studies and the American studies. You have increased breast cancer danger. You have increased cardiovascular risk. Of course, again, the advantages are the bone fractures, and you have increased risk in continuum. Interestingly, you have decreased risk of diabetes mellitus. So the combination of estrogens with progesterone make the problem. Estrogens alone reduce the problem. But if you have uterus, you need to get progesterone. The question now is, you need to get progesterone? Big question mark. Why you need? Because there is a danger to develop cancer. But every woman develops cancer? No. So the stratification to be done is exactly on this level. Do we need to give progesterone? First, to every woman, if she has uterus. Secondly, could we diversify the mode of administration of estrogen and progesterone, reducing the danger of developing cancer? And this is not done yet. So actually, the big story that all things started was the reduction of neurodegenerative risk of the woman by getting the HRT. The theoretical data, according to research, indicate clearly that the risk has to reduce. The clinical data indicate that the risk increases. There is one only longitudinal study of women, which has been done in Heidelberg in Germany. These people have started very early in the 70s to follow up women every year twice, taking blood, examining for neurodegeneration, and they have two groups, one born 30-32 and the other born 50-52. This is a huge, it's an incredible collection of patients, because we start now to make molecular analysis of these groups to find out what's going on. But the clinical data are very impressive. And the clinical data are that the women in these groups that have received HRT, there is not a single one that developed neurodegenerative diseases. So despite the clinical data, in these groups of 1,002 women, 500 and 502, none developed neurodegenerative disease if she has received, or in association, I don't want to say it's etiological, in association with HRT. So it is, again, here a different indication, saying I have a longitudinal data. Women followed not once in a cut point in a clinical study, but followed individually over years, and these women who received HRT did not develop neurodegeneration. Another important issue. Now let's take breast cancer and analyze it according to the different compounds, both the combined data, so estrogen and progesterone, and the single estrogen, and in different combinations, let's say estrogen with simvastatin and so on. It's a difficult slide. I'm not going to analyze through, but look what is going on here. You start from a high risk by having the classical combination studied in these two big studies, 2003, and adding pravastatin, and you go down to low risk. So the reality is, depending on what women had got in different studies, the result was strongly diversifying. So again, the point estrogen plus progesterone makes this or this or this, it's very easy, very simplified. The reality is you can only evaluate a single woman depending on what other drugs you get in combination with HRT. And this will decide about what is going to happen, in addition to the genetic predisposition of this individual woman for any of these risks. So you see how complicated this story is, and why I personally have the feeling that you cannot speak generally yes, no. You have to see exactly the problems of the individual patient and then decide for the treatment. However, what it comes out is that the longitudinal treatment that was advised before is not good, and I'm going to show you why. You have to give, as I told you, up to 5 years. So this is exactly the reason why I believe that the short treatment is better. Look here, if you start now the treatment early, and the end points, you stop the treatment 50 to 59, 6 to 69, 7 to 79. Look how the risk changes. So again, if you look at the studies that decided, 2003, the two big studies deciding that the women have not to get any HRT. If you look here, exactly, these women were late age. If you go very early age, the risk decreases. So again, the question is when? And the when is in the first, let's say, year or two of menopause for a short period. So this is the period that has to be studied in the future. Later on, the risk starts to increase. So if you want to do good, you have to get this age, and all studies in the future, if any, have to take place in these early ages. If we take now the estrogen formulation, which is the one said is able to protect without increasing cancer, you have here also very different formulations. Looking at these formulations and thinking about how much of the estrogen gets through the skin, I told you it's about 20%, then someone would think for the skin at least, a topical preparation would be better. So if we think about the skin and taking into consideration all this information, we think that a topical preparation, a cream or a plaster, it's better than a systemic treatment. Another issue coming in the last years was DHCA. DHCA was so, it's going to be discussed, so I will stay only on one slide. It's gone up to the hype in the United States. This is the anti-aging hormone. It is and it is not. Exactly like estrogens, there are black and white sides. Of course, osteoporosis improves. They have increase in libido, which is also important. But the libido increase were only in older women, not in the ages we discussed, the early ages. But in any case, you had exactly like an estrogens, the improvement of the skin quality, which is expected because DHA in women mostly metabolizes to estrogen and not to androgen. So I leave you with an open question. I said yesterday I don't have even myself a decision what to advise, and I get a lot of questions, but it's very difficult without clinical studies to decide. What I deny is the black and white story. I deny the no for every woman, as I deny the yes for every woman. But I think we have here a very important issue. We know now that if we apply HRT, we have to do it early, 2 to 5 years. In some cases, few cases up to 10 years with menopause. Then we know that the estrogen substitution is better than the combination. We have the problem that the majority of the women, of course, will need the combination, so we have to find another way for the progestin, or we have to substitute progestin by new compounds. Then the transdermal application, at least from a dermatology point of view, it's better than the systemic one. And if you want to stratify in a clinical study in the future, you have to stratify and exclude women with owned familial and gastrointestinal risk to develop cancer, breast cancer, and thromboembolic risk. And I think if you exclude these three groups that make maximally 2.5% of the women, this is the point, 2.5%. You have 97.5% that may profit, and you cannot punish 100% of the women for 2.5%. And if you think about it, you understand immediately the need. The question, of course, is which company is going to overtake the huge financial risk. Today, everything has to do with finances, to start such studies under the danger that as the studies will start, the first legal causes in the juries will start. So this is the point that someone has to evaluate and see how we go in the future. I've closed with an interesting point. The same committee that had abandoned the HRT in the United Kingdom 2003 came this year with a re-evaluation of the data of these women. And think what? They came out with a reduced breast cancer risk. And they say the longitudinal evaluation does not support the decision of that time, 2003, at least at one of the diseases. I don't know what's going to happen if they re-evaluate in 20 years. So again, the problem is, of course, you can say on a statement on 1 point evaluation, this is cutoff point and these are the results. But the real story is the longitudinal evaluation, and this is why now we evaluate the data from Heidelberg also with molecular means. I hope that we'll get the money from the European Union to do this in the future, to find out what was the reality in women that they were not planned to get in a study. And I think this is the real population. We have real populations that there was not any pressure, financial pressure or commercial pressure. It's their normal life, and we evaluate women on long term that had a normal life, and some they get, some not, and we're going to see what's going on. So I'm not so happy that I leave you with a question mark, but it's better to have a question mark to study in the future, especially the young people who have the time. We just finish little by little. I don't think I'm going to survive a new big study, but I think on the interest of 50%, more than 50% of the population of this earth, we need such studies, but not only on the interest of the 50%, on the interest of 100%, because a healthy woman is very important also for a healthy man. And actually a healthy woman keeps a man healthy. There are studies on that. So we're very interesting to see healthy women. So thank you so much.